Welcome back to another episode of That's an Issue podcast. And this week, Dr. Tara and Yoni Kleschik speak to one of the most fascinating people I've ever met in my life. Now, think of the Mir Yeshiva, someone learning code for the rest of their life. Got that image? Fine. Now think of a Harvard professor. They're teaching for 40 years. Put them together. That's who Dr. Shmuel Mandelman is. I'm not even doing him justice. He's from the yeshiva world background, and he is so far has given the world so much in terms of his clinical studies. And over here, he's a clinical neuropsychologist, educational developmental psychologist. He has a brilliant, one-of-a-kind clinic that you're going to hear about. What does he do? So Arj Barker he's a comedian, and he has this bit of, he's like, I don't need doctors anymore. We have the internet. I can find whatever I need. You know what? If I have a disease, I just check it up. The other day, I went on the internet and I Googled, I had my stomach, he said was bothering me, and he checked WebMD and he said, I know I now have ovarian cancer. I don't need doctors. And obviously the joke is he's a guy, does not have ovarian cancer. But we very often, from ourselves, conclude the wrong outcome, and it happens in the mental health world. Sometimes people get a certain diagnosis that's off, and it's not correct. That's where Dr. Shmuel Mandelman steps in. I can't wait for you to hear this, and enjoy.
Mental health, relationships, those are loaded topics and something that affects every part of our lives. But we aren't having enough open conversations about it.
And that's an issue. Tonight we have another guest on That's an Issue. It's Rabbi Dr. Mandelman. Welcome to the show.
Thank you so much.
Tell us what you do.
Still trying to figure that out myself. I spend the vast majority of my time engaged in differential diagnosis and complex case management. I see 600 new cases a year. In terms of my private practice, I have a multi-specialty group where we have psychology, neuropsychology, psychiatry, social work, and language as a component of that as well. Beyond that, I am the psychiatric coordinator for both Flatbush and Lakewood Hatzolah. I sit in Besdin once a week and consultant to Besdin and school districts, as well as the clinical director of a few programs at Termisar.
Wow.
Okay, well, can we break that down?
Which part of it?
Okay, so can we start with the diagnosis
Sure.
part? Like, what does that mean?
In my mind, the greatest issue that we're facing in mental health is that people lack direction in terms of what it is that they actually need. Many times people will complain that they went to intervention, it didn't get them anywhere. My belief is a large part of that is a result of they were never properly diagnosed to begin with. As a result of that, the treatment cannot actually be informed by diagnosis, and therefore treatment goes nowhere. And a lot of the reputation that mental health has suffered from as a result of being ineffective is truly as a result of there not being sufficiently appropriate diagnosis, and therefore treatment hasn't followed accordingly.
So do you think there's two people are diagnosing the same type of diagnosis again and again and again, and there's like a large group of people that are just being thrown into a group, like an unnecessary group?
I don't know if it's being the same diagnosed over and over again. I don't think there's an appreciation for the complexity of a diagnosis and being able to just truly understand each of the variables that contribute to it and therefore be able to make that differentiation. So, for example, just today I saw a kid who was diagnosed with ADHD. The kid does not have ADHD or anything close to it. The kid has very significant levels of anxiety. And when you have significant levels of anxiety and you're being treated with a stimulant medication for ADHD, all that does is fuel the anxiety further.
Right.
So we see a lot of things that are somewhat murky that have been decided that this is a diagnosis, treatment is followed, gotten them nowhere, and then it gets very complicated because they lose trust in the system and they haven't seen the results. They run around in circles, going from one clinician to the next without truly getting what they need, and burn out both in terms of their efforts as well as a significant financial burden that they incur.
Wow.
That's fair.
So most people who are coming to you have already tried
Most
bunch of
people that
things?
have come to me have already been around the block.
Interesting. So do you think it would be better if someone came to you off the bat?
For who? For them or for me?
No, for that. Well, right, in terms of saving them
In
effort and money.
terms of, yes. Not because they have to come to me, but the point is they have to be able to get an appropriate diagnosis. And oftentimes, diagnoses people receive are actually not from clinicians at all. It will be a teacher, a rebbe, a friend. While they were speaking to a friend, their kid has something going on, it must be the same thing. In fact, as part of my intake process, we'll ask if there's been any previous diagnoses, and then the question is by whom. And you would be shocked as to who it was that gave them the initial diagnosis, and they ran with it and got wherever they have, but really because there was never a sufficient understanding of what was going on, and therefore couldn't match treatment appropriately.
Wow.
Okay. Are there other people doing this?
My background is somewhat unique. I have 4 master's degrees and a double PhD. So
In all psychology-related things?
in psychology, education, educational psychology, applied developmental and behavioral analysis, educational developmental psychology, and then clinical neuropsychology. So the way this evolved was people run to neuropsych to be able to achieve a diagnosis. And they are prohibitively expensive and extremely time-consuming. And what I was seeing is that a lot of the people that were coming from neuropsych didn't need extensive testing to arrive at an appropriate diagnosis. So it sort of evolved as a result of that into what I'm doing now.
So there isn't really anyone else doing that?
There are a few that are solely focused on diagnostics.
Right. I've never met somebody who does this.
Right, so I don't do
this
any
is
treatment
so
whatsoever.
cool.
No treatment. Diagnose and adios, as we say.
Diagnose and adios.
So it's really focused on getting down to the underlying issue, understanding what needs to be done, and then sending them in an appropriate direction to be able to make that happen. So it's diagnostics and then treatment planning, what they walk away with.
That is very cool. It's like so unique.
It's a lot of fun. And you see people who have really suffered very significantly without any real level of relief as a result of the fact they've been running around in circles. And we're willing to do anything in the world to help our children and our spouses. But when there's a lack of understanding and there isn't appropriate diagnostics being done, they just can't get anywhere.
What was the craziest diagnosis that someone came in with that you were, like the shift from A to B was so large?
It's hard to say the craziest diagnosis. I see a tremendous amount of misdiagnosis of autism.
Okay.
Meaning people come in thinking they do or don't?
We're told they're diagnosed with autism, even though there are other somewhat related diagnoses that are far more appropriate. For example, a social pragmatic communication disorder or a developmental language deficit, that if you give any people with a developmental language deficit or social pragmatic communication disorder any of the rating scales for autism, they will show up as autistic without really going through it and understanding the texture of the diagnosis. So a lot of it, people look at just criteria without truly understanding what the criteria mean and how it is that they really have to go dig deeper and being able to actually interpret testing. Oftentimes, people will come to me, they've already done extensive testing, but without truly being able to understand what it means or how to implement anything that was suggested within the testing.
Okay, so that's what you see most often is the misdiagnosed autism.
I don't know, say most often, that's one of the biggest ones because, there's a significant stigma still associated with autism spectrum disorders. And another caveat to this is, there's this whole push in terms of moving away from labeling within the field and really being able to look at it in a much broader perspective because people very much live according to their labels.
But that has a problem because then you can't.
Correct. So as a diagnostician, obviously I believe that there is a value in appropriate diagnosis. I'm not saying that there shouldn't be a class of diagnoses, but when you're telling somebody that they have X diagnosis and in reality they have something entirely differently, their life is going to be impacted significantly as a result of that.
Okay. Just because you said about school districts, so when it comes to school and getting services in a school, like having a diagnosis like autism is actually beneficial.
Well,
so how does that?
So I don't want to get into the political ends of this.
Okay.
So the way that I generally explain it to people is that there's a functional diagnosis and a clinical diagnosis.
Okay.
I only do clinical diagnoses. So when it comes to, do I really believe that you meet criteria and are really embodying what it is that was meant within the autistic spectrum, then I'll give you an appropriate diagnosis. If you're looking for somebody who will be able to make it fit in order for them to receive services, you're at the wrong address.
Okay. Because that's
Do you have a team
common,
of people?
right?
I don't know.
That's common. Like people are looking for something specific.
It's very common.
Yeah.
And again, it ends up being an abusive system. And
Right.
What results oftentimes is the gold standard of treatment for autism is ABA. So what's sort of transpired in the field is anything more complicated than ADHD has now been turned into a spectrum diagnosis. It's become a catch-all in terms of anything that's going on with a child. I deal with it even at an adult level. I saw a case yesterday for Besden that someone decided that the person has Asperger's, which is no longer a diagnosis. It's part of the autism spectrum now. In reality, and made a referral to somebody who specializes within that domain. In reality, the guy was highly rigid and anxious, and would have gone to this person that would have never gotten the appropriate treatment, as opposed to dealing with someone that can actually deal with the underlying anxiety issues that were causing that level of rigidity and the limitedness in terms of his emotionality. So there's a lot of those sorts of things. And again, ADHD becomes a huge issue. To get pharmacological support, non-pharmacological support, when is it appropriate, when it's not appropriate, and oftentimes any child that has having any difficulty with the classroom, their go-to is ADHD,
Right.
without really understanding what an ADHD diagnosis is, why medication can or can't be helpful, and oftentimes schools will mandate it because they're at a loss as to what to do with the child, but not necessarily is that in the greatest interest of the child.
Could you give us a little bit, like, what are the other options?
In terms of ADHD?
Yeah.
So anxiety is a big one. I would say that when we're looking at a presentation within the classroom, the three overlapping areas that are most difficult to differentiate between are ADHD, anxiety, and a developmental language deficit. Because they have a tremendous amount of overlap in terms of actual presentation. Their underpinnings are entirely different, and the treatment that's necessary as a result of that is also extremely different. So we'll have kids who are being treated for one thing, while in reality they have entirely a different phenomenon going on, but as a result of the inability to differentiate between the pieces, that they really don't get what they need.
Wow.
Could you give us some, like, practical, like, signs? How could you differentiate?
It's really about being able to appreciate the full profile. So when somebody is presenting as very anxious, and we don't necessarily see any other areas of deficit, it can just be garden variety anxiety. But oftentimes what people don't understand is that when somebody has a language deficit and their ability to understand the world around them and understand themselves is all processed through language. There's a very limited understanding of what language actually is and what it does and its relationship to any mental health related issues. Anxiety is one of those areas that is impacted very significantly when there is a language deficit. So it's really about appreciating the whole picture. You can't just look at a single variable. And if one actually pays attention to the diagnostic criteria of ADHD or a language deficit, they're specific in nature because they're designed to be able to differentiate between them. So you'll have children that come in and they're in school that they're described as being these absolute monsters, whereas at home they're perfectly well-behaved angels. By definition, when you're diagnosing something as ADHD, it has to exist across multiple contexts because it's an organic deficit. If it's going to be organic deficit, it doesn't discriminate based on specific context. So those are sorts of things that are oftentimes missed.
Fascinating.
And even in terms of people's willingness to really think about a case, look at all the variables, look at it from a developmental perspective, is where oftentimes people will misdiagnose and really never be able to achieve what they need to do, and the fallout is huge. Besides seeing children, I'm trained across the lifespan and see patients from 6 to death, as we say. So we will see adults that were misdiagnosed when they were younger, and it haunts them well into adulthood. So even though they got a diagnosis of whatever it was when they were 6 or 7, I'll have business executives come into the office to better understand their diagnosis, better understand what's actually going on with them, because this has haunted them throughout their entire life, despite some of them being extremely successful.
Wow. Okay, so I'll ask you a question we asked Relief. Are you seeing like an increase in mental illness, like over the past, I don't know, few years?
Again, increase. I think there is an increased level of awareness. I think there's an increased willingness to get help. I think the accessibility of help has increased exponentially. Do I think there's more diagnosis? There's more diagnosis as greater education and more accessibility to care. Do I think that there's something shifted and there's something in the water that's all of a sudden causing it? I would say no. Obviously, there are significant societal pressures that people would love to attribute everything to. I don't think it's quite as simple as that. And then, in terms of post-COVID, also became a very big issue in terms of people's anxiety, overall mental health, their ability to function in the face of any level of stress or adversity. So those are all factors that are at play, but I don't think we can say that there's been, in terms of the disease processes, a change. I think the change has really been in terms of our willingness to deal with it and the accessibility of care.
So can you walk us through the process of what a meeting with you would look like and how that would...
Meeting with me specifically?
Right, and what would that, in your office setting, what would that, how long would it take?
So I have a staff that's very well trained. I have intake coordinators, which they themselves are mental health professionals, either school psychologists or social workers. So when someone calls my office for an appointment, they're first set up for an intake appointment. The reason for that is I want to be able to make sure that it's a case that is appropriate for the kind of work that I do and that it can actually be helpful. When people are desperate, they'll try to squeeze in and believe that I'm going to be able to pull off some sort of miracle for them. I'm not a miracle worker. I try to do good clinical work, but it has to actually be appropriate. So then once they have a conversation with my intake coordinator, I review the intake to decide whether it's truly appropriate or not. And most of them, my staff already has a very good sense as to whether it fits within the scope of our work or not.
What gets cut out?
Things that are not going to be helped with just a diagnostic session. Things because they're larger, more involved cases that are oftentimes just messes because of the stakeholders involved, as opposed to the actual what's going on clinically.
Meaning you want to deal with a clinically complicated case
Correct.
as opposed to...
I don't need drama. I deal with plenty of drama. I get to contend with it on a constant basis, but it's about what I can do in terms of bringing someone in, giving them the clarity in terms of diagnostics, and moving them forward. So there are some specific exclusion criteria that we have, but beyond that, we have a pretty wide scope. After that point, if it's deemed to be appropriate, they'll be booked for a diagnostic consult, and then whenever that comes up, I sit with them. Before they walk in the door, I have all the collateral information from any other parties that may be involved, whether it be teachers, rebbeim, previous clinicians, all already collected. So we're not wasting time and just trying to pull together the pieces. A review of all the documents is done, clinical interview with the parents or the patient themselves, and then the child, and then a formulation is presented, and then treatment planning is offered.
So it's all in one session?
Well, the intake is in one session.
And then the training.
Correct.
Wow.
Right, and then there's all the work in between.
Correct.
Right. In terms of gathering and
In terms of gathering all the
synthesizing,
collaterals, making
Oh,
sure
meaning
that it's
there's-
all together and appropriate.
it. Wow.
So it just makes it a far more efficient process. And it's a process that's evolved in terms of a way that we can be most effective and most efficient in offering the highest level of care.
Wow. Can you share with us the case that stumped you the most?
That's a good question.
So, stumped me the most. Anyone who's going to claim they were never stumped is lying. I don't know if I can pinpoint the specific case that I'm like.
Did you have like a ball that you were bouncing off a wall?
So at times, I would
got
like
your house
to.
reference
I
in.
got my house.
At times, I would very much like to have a ball to bounce against the wall, and but
Oh, is there a whiteboard? Is there a whiteboard in your?
so really, in Princeton, in the Institute for Advanced Studies, the hallways are just chalkboards. So I really wanted to do that, but my office is very cleanliness and professionalism is something that my staff very much values. So they banned any sort of things. And when I spent 5 years at Cornell. I worked in the neurosurgery department and the psychiatry specialty center. There in the office, there was whiteboards everywhere in the office. So we had that experience.
Got it. So what case would you say that you had that was diagnostically?
So part of what I do is I deal with a lot of medically complex cases as well. Given my background in working in neurosurgery, I deal with a lot of neurological related issues as well. So it's not when
what do you mean by neurological related?
Epilepsy, brain tumors, traumatic brain injury, things along those lines, concussion. I worked on the concussion.
CTE?
Sure. I worked on the concussion team for the New York Jets and the New York Islanders while I was at Cornell. I've seen lots of professional athletes, professional boxers, horse jockeys, all of those. So in recent time, when we're looking at a case that presents partially as medical, partially as psychological, those are some of the more difficult cases to really be able to make significant headway within. There's something called conversion disorder. Conversion disorder is when there's an extreme anxiety or trauma that the body cannot process, and it converts, quote unquote, into this disorder where we see that there is no organic basis for the physical presentation. It can result in blindness, it can result in paralysis, where we see true physical symptoms without an etiology being able to be identified as organic in nature. And those are some of the most complex cases any clinician will ever see, because how do you truly differentiate what's psychological and what's medical in nature? So those are some of the more challenging ones, and part of what is my job is really first diagnosing it as a conversion disorder. So given my background as a neuropsychologist and having that neuro background helps me being able to really distinguish between what do I think is organic, what is not, and then make that appropriate diagnosis, because you can have treatment in terms of you believing that this is neurological in nature. I've had cases where they've done multiple surgeries for something that didn't actually exist, and the whole time it was really underlying it was a psychological issue such as conversion disorder. I've had patients that presented as completely paralyzed, which was really only a question of there being an underlying conversion disorder.
Wow.
And conversion disorders are one of those things that are extremely difficult to treat, and there are very few clinicians that treat them. There are actually very few centers throughout the country that treat them. So those are some of the more complicated cases. From a neurological standpoint, we'll see cases of autoimmune encephalitis, which is basically a brain inflammation which is your own body causing an inflammatory process, which causes inflammation within the brain that can cause a whole host of both physical and psychological issues, which are very difficult to identify. So I have a number of those cases that I am involved with and help manage, both from a neuropsychological standpoint and then in terms of treatment protocols moving forward from there.
So you work with, hand in glove with other doctors
Sure.
as well?
part of the beauty of the field is when you're able to collaborate with people that are like-minded and have expertise that complement each other. So sort of the vision for my practice was I studied at Yale Child Study Center, where you have this comprehensive team approach. And then again at Cornell Psychiatry Specialty, it's also very much a team approach. So in my office, the reason I have those variety of clinicians is I don't believe that a person is unidimensional, and you need to have those multiple inputs. So we do case conferences and things along those ways, so we can get all the best and the brightest around the table and really hash it out. So I work with neurologists, I work with psychiatrists, I work with neurosurgeons, I work with pediatricians, the whole gamut.
It's so fascinating. Okay, I want to ask you a question about neuropsychs, because I'm asked this question often, and I'd love if you could give me like a good answer. When would you say someone should go like pay for a neuropsych?
When do I say? When do others
So why
say?
is that? Why do you get asked that question?
Because it's a very common question, for sure, with kids.
It's a very
Saying, I work
common
in a school,
question,
so-
and so neuropsych is basically, for those who don't know what a neuropsych is basically a survey of brain function, where we look at everything beyond academics. So when they're school age, we're much more concerned and focused on academics. When there's obviously medically related issues, we're not as focused on academics, looking at overall function, but it runs the full gamut of cognitive processes. So we look at memory, we look at attention, executive function, spatial planning, 4 types of memory. We look at motor speed. We look at all of the underlying processes, including language, that support cognition. Now, the reason why people like neuropsychs is they're very rich in terms of the data they can offer. The downside of them is oftentimes they are prohibitively expensive, given the amount of time that goes into both conducting it and then people complain about the ticket price. What they don't understand is however much face time they got, it's twice as much in terms of the interpretation and write-up. So if you do a testing session for, let's say, 6 hours, you're doing at least another 12 hours of interpretation and write-up. I happen to be, despite being a neuropsychologist, I'm very selective in terms of the neuropsychs I'm willing to do. And the only time I'm willing to do a neuropsych either is because it's medically indicated, or that it's such a complicated case that no one's been able to make heads and tails, and there's inconsistencies within the presentation that need clear data to be able to substantiate what's going on. Outside of that, a good diagnostic consult can very much address the vast majority of things, particularly if there's some baseline psychoeducational testing that can be done by the school district for free.
Yeah.
Clinicians love neuropsych because it gives them all of the answers, because neuropsychologists, besides being clinical psychologists, they have specialized training beyond that. So psychiatrists are extremely neuropsych happy. A neurologist's only objective data comes from neuropsych. And schools like it because it gives them a full gamut. So because beyond the educational and the psychological aspects of it, we can look at personality, we can look at anxiety, we can look at all of those aspects as well. And you get a nice document with it all laid out very well and a very specific format that really gives you a full survey of what's going on with that child at that time, and can give you insight and understanding as to where the child is at and what they sort of need. So my personal philosophy is I only recommend neuropsych when you simply cannot figure out what's going on, or whether it's medically related. Outside of that, I shy away from neuropsych. I turn down neuropsychs every day.
Right. Like it's not just for the average kid who's not doing well in school.
I don't believe that is the power of neuropsych. Power of neuropsych is when we really can't make heads and tails of it. We need something larger. We need something far more comprehensive to pull together those pieces. Outside of that, I think that there is an overuse of it. My neuropsych colleagues may not particularly appreciate that because it might affect the business model. But in terms of its diagnostic power, it really is an extremely powerful tool. But I believe only in leveraging that when it's absolutely necessary, given the significant amount of time and financial cost that is involved with it.
Okay. That answers my question. Okay, I know you don't treat.
Correct.
But I'm trying to think how to ask this. Can you give, let's say for a parent of a kid, school age, let's say we go with that, that's exhibiting ADHD, anxiety, all those type of symptoms, like what would you tell them to do? Like where do they
Hold
go
on
first?
tight. So it really depends what the presentation is, because ADHD can present in a variety of ways. So really, and even diagnostically, the way we want to understand it is where we're seeing a functional deficit. And sort of the threshold that we use across the board when we're looking at something clinical is where is the impact in their lives functionally. So we always have to look at a point of entry when we're doing any level of intervention, in terms of where are we going to be able to get into this problem and where we're going to get the maximal effect. So really, depending on what the kid is presenting as, is really going to be what the direction is. Is this somebody that needs more of a behavioral management style? Or is this somebody that needs pharmacological intervention? Is this somebody that needs really more in terms of the base psychological work to be able to support them before we can even touch that? And then there are kids that really just need more of an executive function person to help them work on developing those skills, because most children that present with ADHD present with executive function deficits, even though the opposite is not necessarily true, where you can have executive function deficits without having ADHD. So it's really specifically tailored to the case and what the presentation is. Additionally, it also depends on the parental quality. Parental competency is a huge variable in all of this. And
Okay, so what do you mean by that?
what is the parent's capacity? What are they capable of in and of themselves? What is their own mental health status? And really being able to understand if I'm going to be collaborating with a parent who is overall psychologically healthy, that they have a relationship with their child, that they'll be able to be effective in this, and that they will actually be able to do some follow-through. Oftentimes, what we'll see is that parents get overwhelmed, given the complexity of their children, and or their own pre-existing issues, and will end up making very little headway, but it's not really the kid's fault. A lot of it is just because of the parental dynamic.
What do you want the parent to be able to do? When you say follow through, what do you want them
follow
to do?
through? Some of them don't follow through at all. There's not even a basic level of it, but there needs to be collaboration between all of the stakeholders. So sort of the model that I think within is that of developmental psychopathology. Which is the study of how pathology actually evolves and develops. And the richness of that is really because it's pulling from multiple disciplines and taking in all the variables into account. So looking at the parents and understanding what's their own history. Do they present with similar issues? What was their trajectory like? These are all variables that are going to predict as to where this is going to possibly go. So let's see, whether it's ADHD or anxiety, and you're sitting in a room with two highly anxious parents, you know where the kid got it from, and you know that their coping skills can be compromised. So the level of intervention oftentimes is not even at the child level, oftentimes at the parental level. There's a tremendous amount of work that can be done through the parents as a result for the child directly, depending on the quality of the parents. And then there are parents who are phenomenal parents who love to run the parenting classes because they feel extremely empowered by them. But in and of themselves, they're great parents. Then you have others who will shy away from any level of parental work, and really that's where it needs to happen. It's something that is very much a confounding variable in much of the work that we get to do.
Okay, so back to my question though, of like, what do you want the parents to be doing?
Depends. It depends on what the case is.
Well,
Is
so
it-
let's
is
say
it
let's say a ADHD case.
No, but even an ADHD case, are they hanging off the chandelier? Are they just spacing out during math class?
Right.
Those are going to be two very different presentations with very different interventions. So is it that they need to be having more collaboration with the school in terms of figuring out what is it the school is seeing? Is it that they need to be working with somebody that can help with some of the executive function skills? Is it that they should be following up for pharmacology? And are they willing to take that step, even if it's necessary? Sometimes parents will say at all costs, I will not do that. And for good reason. And pharmacology is scary, and no one wants to put foreign substances in their child's body, but understanding when there is an appropriate reason to do so, when it is that we believe that that will be a point of intervention that's going to be a game changer for the child. So follow through really depends on the dynamics of the case.
Right.
That's the short answer.
Right, but it's complex.
Humans are complex.
What about like the more, sinister type of, not sinister, but more challenging or, things that, challenges that people have that hurt other people. So, ADHD, that challenges some, primarily hurts the person who's suffering from that. But where you're diagnosing somebody that is harming other people.
So one of harming other people because of, that really depends. So if it's an organic mental illness that results in either aggressive behaviors, it's very different than we have somebody who's engaged in abuse because of a different pathology. So I don't do offender work because you're very limited in terms of what you actually can do. But oftentimes what we will see is people that are suffering from something like a acute mental illness that's chronic in nature, whether it be a bipolar or schizophrenia, that can end up becoming extremely violent and dangerous if it's not diagnosed appropriately or managed well. And it's always taking into account all of the whole picture. So why is it that it's presenting as such? And even when you say that ADHD kids are really only hurting themselves, oftentimes their siblings are very significant targets for physical aggression. And really understanding why is it that a child's becoming aggressive. And I had a kid in the office just last week a school refusal case. The kid hasn't been in school in months, and I'm pretty good about getting under people's skins pretty quickly. It's one of my talents. In 30 seconds, I had the kid totally unraveled, and literally physically aggressive against the father throughout the entire session. And the father retained his composure the entire time, did not flinch. And what was really going on there is that he was a very bright kid. And he had an unevenly developed cognitive profile, as well as having asynchronous development, meaning that cognitively he was in a very different place than he was socially, emotionally, and he was extremely dysregulated. He had transitioned within the school year from different sets of demands, totally lost it, and so outwardly he's extremely aggressive and on medication prescribed to manage that level of aggression, but in terms of what it was that was actually going on underneath it was totally misdiagnosed and not understood. And the sense of relief that the parents had that they finally had a working formulation to understand what their child was really all about was totally, for them, it literally gave them a new lease on life. They hear they're contending with this child that in my office itself, we were dealing with significant levels of aggression, and really it was just about a child who doesn't know how to be able to regulate appropriately and perceive the world as a threat, and therefore, even though it doesn't look like it's commensurate to what the trigger is, in his mind this is all existential in nature, and therefore the kid was responding in the way that he was. So even something as seemingly basic as ADHD really can have significant components. And another piece that I feel is oftentimes missed is that we're not looking at a child holistically. We try to separate between the social, emotional, academic, behavioral. You got one kid.
Right.
Every one of those systems is extremely, extremely interconnected. And really being able to understand how all of those pieces come together is where we can start to be effective in terms of intervention. And that's oftentimes entirely lost. As we said before, that sometimes anxiety can really be secondary to language deficit. Oftentimes, many behavioral issues can really be secondary to an academic deficit. And truly understanding what that academic deficit is and how it is that it can be remedied is really where we're going to get the greatest gains made in terms of intervention. So it's really taking that entire picture of the child, not looking at it within a silo, but rather understanding that it's one being and all those pieces are entirely integrated, and then being able to take that and figure out where to go from there. And one more point in terms of your aggressive behavior. So part of the work that I do is I'm the crisis team leader for mental health emergencies for both Flatbush and Lakewood, Hatzolah. And oftentimes we will be called when there is violent or aggressive behavior. And that's something that we as Hatzolah members have to contend with, because the first place anyone's going to call is Hatzolah. And oftentimes people who have not been compliant with medication, or they're having their initial psychiatric episode, will become very violent and dangerous.
Oh, wow.
So that's something that we train in terms of de-escalation techniques, understanding how to keep them safe. And there's been, in general, even within the larger population, and even in terms of law enforcement, work done in terms of understanding how to be able to approach somebody when they're in the midst of a psychotic episode or they're manic, because when someone is in that mode, there's very little holding them back. And you have no idea where they're going next, and you're sort of a sitting duck when you're in close proximity to them. And this is not on their own volition. They don't have control of themselves when they're in those moments, but yet they can become extremely dangerous and aggressive. So in terms of hurting others, that's another area that isn't often times thought about within that context, but is something that's very real for those that deal with crisis and emergency.
So do you deal with spousal, people call you for, call Hatzolah and husband or
so
wife?
So oftentimes we will get called on for domestic issues. We don't do domestic counseling. Our job is to make sure everyone is safe, and if someone is not safe, to be able to make sure they get to where they need to get. But we don't do shalom bias in terms of walking in and, trying to mediate a situation. Shalom bias is a big issue within mental health in general. Like you mentioned earlier, I get to sit on Besdin as a consultant and work through some of the mental health issues that are resulting in the significant shalom bias pieces, and something that's not sufficiently appreciated or understood in terms of the extent and the prevalence of how mental health issues are impacting marriages. Oftentimes undiagnosed previously, manifest very significantly during the course of the marriage, and then the impact that it has on the marital relationship.
Right, can we talk a little bit more about that? I know that's
Sure.
We're going on a totally different topic here, but
We're all about different topics.
could you talk a little bit about, I guess we could start with what the impacts are?
Impacts are, you have spouses that become extremely alienated. They can develop their own maladaptive coping strategies. And obviously the most important factor here is that children become collateral damage. And when we're looking at a dynamic such as that, until there is clarity in terms of what's actually going on in terms of the mental health of the individual spouses, in terms of how that's impacting the children, all of those factors are very significant. I saw a case just yesterday. There was a referral about a kid with behavioral issues, and it actually resulted in being much more of a negative marital dynamic, that the parents literally were not on the same page about anything at all. Husband was very checked out. Wife was very emotional in terms of all the pieces that were coming up. And I simply explained to them, whatever you guys are going to do in terms of your marriage is not my problem. I can just tell you that the reason why your child is where he is right now is that he has zero safety and security in the world, as a result of the marital dynamic that's going on. And people have no idea.
Cut right to the core.
Yeah, we don't waste time. And that's part of when given the model that I operate within. I'm not going to sit there and massage egos and make everyone feel good. I want to make sure that we know what's going on, what's actually wrong, and how we can fix it. Which some people appreciate that approach more than others. There are no kid gloves in my office. We're going to do this well. But to understand that when a child is feeling that unsafe and they never had that appropriate attachment to begin with, you're going to get behaviors that are extremely escalated without parents that are going to be able to help regulate the child when they themselves are so dysregulated.
So when you say check out, what do you mean by that? What does that mean?
Emotionally unavailable, not engaged, not willing to be able to really be part of the process to be able to help that child feel where they are. And the child then feels they got nobody in the world. And children need safety. And that's one of their core elements that they need. And they need it on a constant basis. So when that's not there for them, their behaviors will escalate very significantly. And there's very little balance.
Or it's just young age?
No. Human beings in general. Children will see it as sort of the most extreme presentations of it. But we'll see it in adults, even though they're adults. if you wanted to take all of psychology and distill it into two basic fundamental truths, everyone wants mommy's love and daddy's approval. When those things are not available to people, even well into their adulthood, it has a very significant impact on their ability to function.
And you'll just tell it to them straight.
Yeah. There's a reason I only do one session.
Okay, but now that you made that like statement, let's say someone didn't get it and they're an adult now.
So,
like, what do they do?
So, again, going back to understanding development, basically our early attachments end up being the model for our future developing relationships. And oftentimes, so I want to make an important distinction. Within the field, there are people who all they do is talk about childhood and do everything down to rebirthing experiences to create attachment to the child. The term attachment, as it's used in the common vernacular, particularly within the community, I would say, is not true attachment. They will blame everything on attachment. If we're going back, to the work of John Bobley in terms of secure base and really going down to the foundations of how people start to develop and understand themselves.
No idea what you're saying.
Verbally, of course. I don't know why anyone's laughing.
So when they don't have that, they don't develop that sense of self because they don't have the security to do so. And as they become adults and they have to have intimate relationships with others and really being able to have a level of vulnerability, being able to share, being able to partner, if that wasn't there, they struggle very significantly. And that's just when they didn't have appropriate attachment. We're not talking about when there was actually trauma. And again, I'm talking about trauma, not because I stubbed my toe and I had a bad day and therefore I had trauma because my mom yelled at me once. I'm talking about true developmental trauma when there was any level of abuse, when there was any level of neglect, which is far more prevalent than anyone will ever acknowledge, and we get to see the outcomes in terms of adults.
Right, okay, wait, so I'm going to ask my question again. If someone, let's say, had that
they have to
experience and it's sad, what would they do?
They have to do the work in terms of really developing a sense of self, being able to find and understand securities that are not going to be coming from mom and dad, but really being able to have some of that internally. And again, in terms of relationships, people are not willing to own their own messiness, and people are not willing to acknowledge their own needs. And as a result of that, they end up doing stupid things. And will start to alienate people, will start to do things against them instead of understanding, no, this is actually what I need from a psychological standpoint. So when they didn't have those early pieces, they really need to do a tremendous amount of internal work to build that stable self. And again, we don't have to get Freudian. I'm a developmentalist, not an analyst, in terms of having that stability internally to then be able to forge forward in life. And in general, whenever there's any level of adversity, how it is that people respond to that adversity is going to be very much dependent on what their protective factors are. So there's a big push. Everyone's talking about resiliency. The funny thing is you can't teach resiliency. Resilience, by definition, is an adaptive response to an adverse circumstance. So people talk about it as if it's like a subject you can teach in school. It's real life, and it is how it is that people respond to those real life experiences that make someone resilient or not. And resilient and resiliency are not the same thing, even though that people use them interchangeably. They are not meaning the same thing from a definitional standpoint. So it's about really building those people as human beings first so they can contend with the realities of life in a different way as opposed to just crumbling. They will be able to cope far better.
Okay, so related question. As parents who want to do the right thing and attach to our kids securely and all that, what do you have any tips in terms of what you should do?
One rule: get over yourself.
Separate yourself from.
Get over yourself.
Kid.
Your child needs you. This is not about you.
Right.
And I think it's one of the biggest problems that parents have, particularly if they've had anything going on in life beforehand. They have a great difficulty actually meeting the child where they are and understanding what they actually need, as opposed to it being that what the parental need is. So when a parent can truly move beyond themselves and be there for their child in the way their child needs, not because it's necessarily convenient or comfortable for the parent, it, then we can really start to build that appropriate attachment. And obviously, if there are significant mental health issues at play, that impacts their ability to actually be present for their child, be able to really get beyond themselves, because their own emotional needs are not in a place that they can actually just move beyond it. And we see a tremendous amount of that. And I would say the same thing is true in terms of education. In order for teachers to truly be able to connect to their students, being able to get over themselves is one of the most critical components. And as long as there's self-involved and our own processes at play, it's very, very difficult to truly be able to be there for the children the way we need to be.
So selfish or narcissistic?
Narcissistic is a big word. Have you ever met a real narcissist? They're far rarer than people believe. We throw around the term in our general parlance, but a true narcissist is something very special. Very, very special.
The special is a very interesting word.
No, because it's unique. It's something that is...
Like you if someone would walk into your office and you would deem that person to be a narcissist,
I love it.
You would, oh, okay.
I love them because they care about nothing else except themselves. They will cut down anyone in the direction, and I got nothing to lose, so I just have a good time with them. Personality disorders in general are obviously the most difficult aspect of psychopathology to be able to actually treat, because they're innate to the person. So personality disorders are also something that oftentimes are misdiagnosed as something else. So they'll present as an eating disorder, they'll present as significant anxiety. In reality, all they are is they have a personality disorder. And
one of a personality disorder is narcissism.
Narcissism is a personality disorder.
Okay. What are others?
Like borderline personality disorder.
Again, but even true borderline personality disorder is very different. When people walk around and say, oh, they're a borderline. No, it's not they're a borderline. Either they have borderline personality disorder or not. Now, people can have features of borderline personality disorder, and those are oftentimes missed in terms of a larger diagnostic picture. But understanding that personality disorders are the most treatment-resistant diagnosis one can have.
Why?
Because it's innate to the person. It's not that there's something, they can't separate themselves from it in any way. It very much became their whole internal psychological workings. So it's really ripping the person apart to be able to get to them to move forward. So we have, like for borderline personality, obviously we have DBT, which is dialectical behavioral therapy, which is used to manage borderline personality disorder. And obviously, anyone looks at the history of it, we know that it was developed by somebody who they themselves suffered with borderline personality disorder. Borderlines are some of the most difficult people in the world to work with. And they're highly treatment resistant, and oftentimes they're very high risk in terms of patient population, because suicidality and self-harm is part and parcel of what we'll see in terms of borderline personality disorder.
Wow. When I was an intern, I had a patient who came in with that diagnosis, and I was convinced that it wasn't. You're just convincing me more that I was right. It didn't make any sense.
Yeah, so people throw it on because basically if it's something too messy or too complicated, they'll just throw it into the basket of personality disorders without it necessarily being a true personality disorder.
I mean, you'll get cases where that's going to be the
referral.
And really it's something else.
But you can, once you've sort of have a developed sense of it, you can smell them a mile away.
What's the telltale?
No, there's not. It's a profile. These are all profiles. It's not a single indicator. I have zero tolerance for borderlines, and I am one of those.
You have zero tolerance
for borderlines? Yeah.
Why?
Because they're not actually there to get helped, and if they're going to get helped, the way that they present and their whole way of being able to gain attention and being able to interact with people is very off-putting. I had a case once, a very messy familial dynamic. And the wife walked into my office and started right away. I said, I'm sorry, I can't help you. And I said, what do you mean? We waited months for an appointment. And we came, we traveled in. We're 30 seconds in. What else? And I said, I'm not treating a borderline personality disorder. And they walked out the door. And the referring clinician calls me and said, could you do this to me? I said, you've missed the boat here. This is a borderline. This is not for a diagnostic consult for the child. This is about her, and I'm not going there. And
what are the symptoms of a borderline personality disorder?
go for it.
No, you go for it.
What do we see? We see a lot of the neediness. We see a lot of dysregulation in terms of the emotionality. We'll see the way they can sort of turn it on and off for certain people in terms of how they interact.
Like love-hate
They switch. They're extremely emotionally volatile. Meaning that they can become very combustible very quickly. Internally, they're usually extremely insecure. Sometimes borderline personality can result from true trauma, which is then very difficult to treat because you can't really even get to the core trauma because you have borderline personality on top of that. And they're just extremely difficult people to interact with, even at a basic conversational level. So, and then along with that comes the substance abuse, it comes the suicidality, comes the self-harm.
Wow.
But where would it come from if not from trauma, though?
It doesn't have to be a trauma response. People believe it has to be. It doesn't have to be a trauma response. Just like any of the personality disorders, it doesn't have to be in response to something specific. It's just really the constellation of factors coming together to create that level of a response.
Wow. How does substance abuse, challenge your ability to diagnose?
It doesn't challenge it. It totally takes away anyone's ability to diagnose because you have no idea what you're actually looking at.
So you won't diagnose anyone who's struggling with substance abuse?
In terms of it, beyond the diagnostics of what level of substance abuse they have, in terms of getting any nuanced diagnostic out of them, it's very, very difficult. Sometimes what we will see is sometimes with people who are struggling with substance abuse are actually have an underlying mental health issue. So I don't treat substance abuse. I don't diagnose substance abuse, but oftentimes they will show up at my door. And I had a case that just coming to mind because I just had to interact with him recently where long-standing drug use, really underlying that all, he was a raging bipolar. And bipolar together with substance abuse is not a great combination. And by the time he came to me, he had already been using for many, many, many years, had already had extremely erratic and disruptive behaviors. And when I told the parents that your child is not just suffering some substance abuse, what's really underlying that is an organic mental illness, to them, finally, like the pieces started to make sense.
Wow.
And oftentimes, once they're given an appropriate diagnosis, they can go back and do a retrospective review of it, and then really start to see how the symptoms started to align and come together far before then.
Wow. And then when you treat the bipolar,
then you can actually have a chance at overcoming the substance abuse issue. But getting people that have both any level of comorbidity makes it a significant treatment challenge.
Wow. It's a really unique position that you hold where you can direct, people to the place that they need to go.
It's a lot of fun.
It's such a new thing to me. I've never heard of someone who does this. So I'm really fascinated right now.
Yeah,
I
always
just covered
thought
so many different things.
I always thought a doctor, anytime you go to a psychologist, that's their job is to diagnose appropriately. To think that you need to have, you need more is just.
So I'm not here to throw all clinicians under the bus.
You're about to get thrown under the bus.
Although I spend most of my professional career cleaning up other people's messes, but it's about what's the focus. When someone is very treatment focused, they're not necessarily as in tuned or as well trained in terms of diagnostics. Some people will say, okay, we just treat the presenting issue. Well, what is actually the presenting issue? And then oftentimes they'll be engaged in psychotherapy, working on whatever they thought the presenting issue is. But in reality, from a diagnostic perspective, it's something very different. And therefore, they won't make the progress in terms of the therapy work. And a lot of my cases are under current care, where the clinician themselves will refer them for their diagnostic clarity in terms of why is it that they're not making the progress they need to be making, what else can possibly be contributing to this picture here that we're missing. And again, it's really all about the nuance and understanding each of the variables and how they interact with each other and understanding what actually is driving this all together.
Wow.
Mm-hmm. That's so
amazing.
Cool. That's very interesting.
Even the modality that's chosen by a clinician to treat whatever it is that they're treating is going to really depend on diagnostically what's going on.
Right.
So that's something that also there's oftentimes a total misalignment between what is being used within that therapy context and what the person needs, and that misperception is not necessarily because the clinician doesn't have that modality or isn't trained in it. It's that their formulation diagnostically is not really what's going on, and therefore that's been an impediment for the further development and growth of that patient within that therapeutic process.
To be fair, he's not seeing all the times that the clinicians did it right. Right? He's
Those
only
are
seeing,
boring cases.
right? Is that right? So you're only seeing when they mess up, but
Correct.
yeah. Okay.
But given my patient volume, I can tell you there are lots of mess ups.
Yeah.
Could we end with like what's something like you'd want to tell like the average person?
Own your messiness.
Uh-huh.
Humans are messy. When we are uncomfortable with our messiness and uncomfortable with who we are as people, understanding what our strengths and weaknesses actually are, being able to leverage our strengths to compensate for our weaknesses, and being real. That in terms of every person needs that process to be able to move forward in their life.
Yeah, I could tell you're partners with Zimmerman. He gave the same exact message.
We've been partners for a long time. Again, very different approaches, very different personalities. But anyone who's working within this space and seeing what we see, it's the human element that really needs to be understood and appreciated. Even though from a diagnostic perspective, we're not necessarily in that treatment room. We're not dealing with that in terms of in that specific way, but understanding the human struggle, understanding what people are actually contending with, and then being able to empower them to deal with what they're up against is really the most rewarding thing someone could possibly do.
Thank you so much for
Thank
coming.
you.
We really enjoyed.
Really
Thank you.
fascinating.
I love that part where Dr. Mandelman says how, everyone wants their mother's love and their father's approval. Really hit it on the head. You're going to be seeing more of Dr. Mandelman really soon. But first, if you or someone you know needs help, needs a psychologist, needs a therapist, turn to Relief. They're a free and super helpful organization that we love. And you go to reliefhelp.org. You can send them an email, info@reliefhelp.org, or you could give them a call, 718-431-9501. Say you heard about them from us or not. They keep everything very confidential. They're rock stars. And if you're listening or watching this on YouTube, Living the Chaim, please subscribe, or Apple Podcasts or Spotify. Subscribe and rate us 5 stars. Every time you do, me and Yoni high-five each other 1,000 times. So please do that. And until next time, stay safe. Living the Chaim.